Hi there, I'm Clayton LaBaume. I'm a physician assistant and fracture liaison service coordinator at a hospital here in Southwest Colorado. I'm also the chief information officer for RPJ FLS. The other day, we were having a meeting with my colleagues, Dr. Ann Lake and Dudley Phipps, and trabecular bone score came up in our conversation. And, I personally don't have that part as my clinical practice, but I'm very interested in it. I want to incorporate it into my services. And so, we started asking questions about it. And, as we started talking about it more, I kind of thought like, wait a minute, I bet some people have the exact same questions that I have. And I bet that there's other people who are interested in it as well. So we decided to make a recording, and in collaboration with MediMaps, we're here to have just kind of a frank conversation about trabecular bone score. So just to introduce yourself in a little bit more detail, Anne.
Yes, hi, this is Dr. Ann Lake, and I am the fracture liaison clinician and coordinator for a large academic tertiary care center in North Carolina. I'm also the CEO of RPJ FLS, which stands for Right People Joining Together in Fracture Liaison Services. So I'm excited to talk about this great software program to help improve your diagnosis of your patients with osteoporosis.
Hi, folks. My name is Dudley Phipps. I'm a PA at a large private orthopedic practice in Iowa. I'm the Chief Operating Officer of RPJ FLS. I have had trabecular bone score for quite a while, and I think that it's quite important. So I'm happy to be participating in this discussion today.
Great. So, so people know what our mission is at RPJ. It's to help build successful, sustainable, and value-driven secondary fracture prevention programs for healthcare organizations, and help deliver improved quality of care and measurably improved outcomes. And I think, from my understanding, trabecular bone score is a great tool to help improve the quality of care. So
absolutely. I thought you were going to ask me my question. You're going to go on. We're having a conversation.
To get started, what is TBS and what additional information does it provide compared to DEXA scan alone?
So you mentioned that we want to improve the value of care that we're giving our patients, and improving the value means making the right diagnosis and putting them on the right treatment and monitoring them. And we know that with osteoporosis, it's not just simply low bone mineral density, but it also has to do with the microarchitectural deterioration of the bone tissue. But we have no direct measurement of that. We haven't, unless we've done bone biopsies, and we're not having people standing in line to get those done. We talked about that the other day, right? So what do we have available? Well, we have this wonderful software called Trabecular Bone Score. It is bone mineral density software program that estimates the bone texture information from the PA of the spine on the DEXA. It's a unitless measurement, so it's not a physical measurement, but it gives a comparison pixel by pixel photon X-ray absorption from the actual DEXA scan. The way I like to describe it is, if you're looking at an iceberg, and you're looking at the top of the iceberg, that is your macro architecture, and we can see that on BMD. It's the reflection of that iceberg in the water that is the micro architecture, and that is what the TBS gives us. So we're not getting a direct trabecular bone score from the vertebrae or the BMD. It's a surrogate measure that tells us of the bone microarchitecture. And the beautiful part of the TBS is that it's being used worldwide, and it actually provides information about fracture risk additive to your bone mineral density and your clinical risk factors.
Great. So Dudley, I'll let you take the next one. What are the clinical applications of TBS?
Well, again, whenever we're looking at anybody that comes in through a fracture liaison service, ultimately what we're looking at is not a diagnosis of osteoporosis, but ultimately what is their fracture risk. And we need to know what their bone strength is. So bone strength is a combination of quantity of bone, as seen on a bone mineral density test, as well as the quality of bone. And the TBS allows us to get a better handle on quality measures and then incorporate them into a validated fracture calculator such as the FRAX.
Great. So, clearly, I can see where this has a lot of potential for, screening, primary prevention. But what if I have a patient who's already had a fragility fracture? We know that their risk of another fracture by definition is high. Um, is TBS still beneficial in patients like that?
Yes, so one of our studies, it was done several years ago by Dr. Ethel Cyrus, and it showed that a majority of patients with fragility fractures actually had low to normal bone mineral densities. And so that means obviously their bone mineral density was not less than minus 2.5, but it was in that low to normal range. So we had to question, why were they fracturing? When we look at the BMDs in a lot of our patients, especially with secondary causes, which Dudley will address that shortly, but with secondary causes, they can often have a normal bone density, but they've had a fragility fracture, and therefore, or their bone density can be low, and so therefore their frax is going to end up being low a lot of times, when in actuality, this patient actually is at high risk. So what the trabecular bone score gives us is an additional tool that we can actually put into the FRAX score, which will reconvert what their risk factors are. So in essence, TBS can be utilized to adjust for the FRAX. So the higher the TBS, the FRAX actually goes down. So their fracture risk goes down if their trabecular bone score is higher. But if their TBS score is low, then their fracture risk goes up. So in a patient that you're only using a BMD measurement on and you're doing their FRAX, you may actually miss somebody that actually needs treatment. But if you have that TBS additional technology and you have that conversion in there, you can actually identify patients more astutely that would be at risk and would be otherwise missed without that technology.
All right, Dudley. So you've explained, how TBS is a good predictor of fracture risk independent of BMD and clinical risk factors. How can it help us identify higher risk patients due to secondary causes?
Well, there's a number of secondary causes, Clayton, that actually impact the quality of the bone. Items such as renal disease, diabetes, glucocorticoid treatment, aromatase inhibitor treatment. These all affect the microarchitecture of the bone. And again, some of these patients may have a rather normal looking BMD, but their microarchitecture, whenever you can pull that out separately and use it as a separate indicator of risk, gives you a much more clear picture of what their actual risk is.
Is there any role in monitoring patients on treatment?
It has been a controversial point up to some to some degree, because I guess some of our technology and the science has not really advanced itself to use this software, but we are seeing a lot more advances in that. The key point to remember is that you should expect different bone mineral density and trabecular bone responses depending on what medications are doing in the bone. So, for example, we know that there are treatments that are known to positively affect the microarchitecture. Those are our bone anabolic treatments, right? Well, then we have the ones that are only slowing the bone loss down, helping with remodeling, but slowing bone loss down. So with the anabolic agents, you would expect to see an improvement in the microarchitecture, which you should effectively see as a response to TBS in the TBS, right? And so one other example, or just we were talking about treatments when we had our conversation the other day, and just kind of dummying it down a little bit in the trenches as in our practice every day. What about the medications we're using and how can we explain TBS to patients? Well, with our bone anabolics, we know that they should increase bone mineral density and trabecular bone score. We know that bisphosphonates, they are going to remodel a transient and cause a transient increase in BMD, but really may not have any effect on TBS score. And if any, it might be very minimal. We know that estrogen, it has a slight increase in BMD, but very, very little effect on TBS. Your steroids are going to have a structure deterioration or a negative effect on the BMD and TBS. Your aromatase inhibitors, as Dudley mentioned, are going to have that negative effect on BMD and TBS. So your BMD will lower and so will your TBS. Androgen deprivation therapy, we see the same effects. So the key point here is that we can actually use the TBS to monitor how effective our treatments are with our patients, and effectively looking at anabolic response and making sure that we haven't had a decline if they're on an anti-resorptive response. But I love it. I mean, we've been using TBS at our organization probably for at least the last 5 years, and I know that I've treated more patients because I've had that TBS documentation related to secondary causes, but also looking at the medications that we're using and being able to explain to patients the importance of that change, whether positive or negative based on their treatment.
Okay, so a couple of technical questions. From an aspect of our DEXA technicians, does doing TBS, does it add any additional time for how long it takes to do a scan? Dudley, I'll let you take that one.
TBS is a post image capture software. So it does not change the capture time for the text. This is all post-processing software. So all they have to do is remember to run the TBS report.
Perfect. And another technical question for you.
Yes.
I know that there's limitations in regards to DEXA scan with patients with like degenerative disc disease of the spine. It can falsely overestimate BMD. Mm-hmm. Is there any situations like that where TBS can't be used or is kind of limited?
Absolutely. So one of the secondary osteoporosis problems in patients is ankylosing spondylitis, or as you mentioned, we've got these patients with severe spinal stenosis and degenerative disc disease. The beauty part of the trabecular bone scoring technology is that it is less affected by degenerative changes in the spine. So osteoarthritis patients with osteoarthritis in the spine, we may not get that BMD result, but it's the TBS is less impacted by the OA as BMD results are. So it actually will give you some microarchitecture information for that spine, which is so critical because we know that our vertebral compression fractures are the ones that are often missed. They have these spine fractures that were unknown to them and they're underdiagnosed. And so if we can capture that TBS in that patient that's got really bad arthritis in their spine, we know a lot of them have already compromised bone structure anyway. So it's just another great tool to have for your patients.
That's a big reason why I'm interested in it, because a big part of my patient population are people that need orthopedic procedures, spine surgery, and those types of things. And oftentimes we can't even look at their lumbar spine scores because they have some pathology in their spine. So I think that would be greatly beneficial. So to kind of wrap this up, Anne, any final thoughts on the clinical benefits of TBS?
Absolutely. So when you have a patient that's had a fragility fracture, you have your BMD, that's great. You already know they have osteoporosis, but we know that clinically, sometimes it's hard to convince patients, right, to go on treatment if their bone density is not that bad, yet they've had a fracture. So one of the benefits is with your osteopenic patients, the combination of TBS and BMD will result in a reclassification of really about 30% of those patients that would have been otherwise classified as osteopenic. But if you have that TBS, then you have that other predictor, and so it's complementary. So it gives that greater, if you will, push and confirmation to the patient. We know that TBS is a great predictor for vertebral and non-vertebral fractures in both men and women, independently of BMD, the clinical risk factors, and FRAX, by adding that textural microarchitectural component reflecting the bone microarchitecture. We know it allows us more patients to identify that are more at risk for fractures. It can fine-tune our therapy decision and help improve with patient management. We also know that it helps with monitoring bone status and treatment effects across time by adding that textual component that's reflected in the microarchitecture. And really for me, I guess the take home message is anything that I can do to help my patients have a better understanding of what their bone strength looks like, what the quality of their bone looks like in conjunction with their bone mineral density. That is very convincing to them, especially if they've been in the position of a fracture. It helps them have a better understanding how the medications work. It can help enhance compliance with patients and convincing them with that additional bone parameter, and encourages them to stay compliant, take their long-term prescriptions, have the follow-ups appropriately, but really with the ultimate goal of improving their outcomes, improved value of care, and helping them remain as active and independent as they can without a fracture in their future.
Well, and additionally, I'll add to that, Anne, from a clinician standpoint, if I have somebody with a low energy or a fragility fracture and they come back with a BMD that's in the low bone mass range, the insurance company may not authorize the most appropriate treatment. And trabecular bone scoring gives us additional information to provide a more accurate picture of their fracture risk based on FRAX, which the insurance company understands also. So sometimes it helps clarify the information, not only for the patient and the clinician, but for the insurer as well.
Great.
And we all deal with that, don't we? Every day clinically. Yeah.
Too much.
Thank you so much,
Well,
Clayton. This has been great.
Thanks for spending your time.
This.
Honestly, this has been valuable to me. And, you know, on behalf of RPJ, FLS, in collaboration with MediMaps, we hope you've also enjoyed this video as well, and found it as valuable as I have. We are going to post a link under the video that is going to have a link to MediMaps that you can click on, and you can learn more about TBS. You can, you know, contact them for information as well. Anything else to add?
I think we're here for you all. If you have any questions about your FLS program, be sure to reach out to us at www.rpjfls.com, and we're happy to help support your endeavors. We're all in this together, and we want everyone to live a healthy, happy, bone-filled life without fractures. So fracture-free future, everyone, right?
Couldn't have said it better. That's
Thank
a good
you
way
so
to end
much.
on this. Awesome. Well, thank you very much.
Thank you.
All right.
Thank you, everybody.
Good night.